Thank you very much, and it's a great honor to speak at this terrific symposium tonight. I've been asked to update a few areas of medical therapy in IBD, and so I'm going to very quickly go through where we currently stand, and I think that this is just to remind people, and hopefully there will be agreement. We have very good first-line therapy for active ulcerative colitis, namely the 5 ASA products, which can be effective in inducing remission in the majority of ulcerative colitis. Oral 5-ASA products in combination with rectal 5-ASA products or rectal steroid products can be very effective for ulcerative proctitis or proctosigmoiditis, or refractory ulcerative colitis in which the rectum and sigmoid colon are particularly problematic. Not only that, we've seen for many, many years mucosal healing with the 5-ASA products in our ulcerative colitis patients who respond. While oral steroids can be effective, they are very limited due to the major side effects which everyone is aware of. With regards to Crohn's disease, we do not have good first-line therapy. The 5-ASA products are inconsistent and have only modest effectiveness in Crohn's disease. Oral 5-ASA products may be helpful in some patients with mild Crohn's disease of the colon and or terminal ileum, but it's a small percentage of patients. Antibiotics are of modest effectiveness in terms of symptoms. We use them obviously selectively for perirectal abscesses, etc. Oral steroids, again, are effective, but the side effects limit their use. So the first-line therapy for Crohn's disease, in contrast to ulcerative colitis, while they may improve symptoms in patients, the Crohn's disease will still progress. You don't see mucosal healing, and you still get complications. The immunomodulators can be very effective in Crohn's and ulcerative colitis, and methotrexate in Crohn's disease, and can induce and maintain response and remission. In addition, have beneficial effects on quality of life and lead to prednisone discontinuation. And mucosal healing can definitely be seen in a significant subset of patients who respond to 6-MP, azathioprine, or methotrexate. And these drugs can prevent progression and complications of disease. Finally, of course, the biologics, including infliximab, adalimumab, and certolizumab, can be effective, as everyone here knows, induce and maintain remission. Natalizumab we use in selected cases. And the biologics, of course, can induce and maintain long-term remission in a significant subset, about 30 to 40% of patients. So it's a subset that really responds well. And in those patients, mucosal healing, quality of life, fewer hospitalizations are seen. And again, the biologics can prevent progression and complication of disease. So, what are the controversies? Where do we sometimes make mistakes? And by we, I mean myself, which is the way you learn about mistakes. First of all, should we do step-up therapy or top-down? You've heard this debated many times, and I'll make a few comments on this debate. On the left, that's me, very carefully stepping up the mountain. On the right is Dr. Bo Shen, as you can see, just jumping right off the top. This sort of summarizes many of the debates that we have had, but I added a word, and that word is uncomplicated, and that is step-up therapy is very appropriate for mild to moderate uncomplicated Crohn's disease or ulcerative colitis, whereas top-down therapy is very appropriate for moderate to severe uncomplicated Crohn's disease or ulcerative colitis, and I'll explain why I added that word in a minute. Now, the alternative to using either step-up or top-down, of course, is to use both together. And again, these studies have been done in uncomplicated patients. Patients with complications were excluded from the trials. And again, in moderate to severe patients. And the issue is that top-down therapy in patients with complications does not start with medical therapy. And that includes strictures, internal fistulae, abscesses, phlegmon, severe disease, bleeding, etc. And one of the mistakes that I think we commonly make and people don't understand is that patients who have complications were excluded from the trials. And I don't think we can extrapolate from trials using patients that didn't include strictures, didn't include fistulae, to then using drugs in patients that have these complications. And I'd like to say, everyone might hear say, oh, that makes sense. But we all make that mistake because the patient says, I don't want surgery. And so we start pushing, and I see many patients where biologic after biologic after biologic has been used in the face of a fibrotic stricture, where people say, well, it's 80% of fistulae, but it's perirectal fistulae that is so effective in, not colovesical fistula or internal fistula or enterocutaneous fistulae, etc. So that we need to revise our paradigm in action. And when we send the patient to the surgeon, and the surgeon says that patient isn't appropriate for surgery because they haven't failed a biologic, we need to be willing to make the argument that if there's a complication there, we need the patient for surgery first and biologics or immunomodulators later. Now, one of the things that adds to this approach is the issue of post-op recurrence, and everybody's familiar with these slides. Over the years, we haven't had anything which really helps us until the slides that Miguel Reguero and colleagues did, shown on the bottom, that very nicely demonstrated such a dramatic result with infliximab. So does this mean every patient after they've had an ileocolic resection should go on a biologic? And I think not. Although some people jump mistakenly to that conclusion. If you really think about it, I just showed a slide in which we kind of summarized a lot of biologic data that they work very well in 30 to 40% of patients. So why should we give a drug that only works in 30 to 40% and not in 60 to 70% to a patient who hasn't got recurrent disease yet and expose them to the side effects? Furthermore, when not everyone develops post-op recurrence. And so the other strategy is to substratify. And I think this is what we should be doing in most cases. That is, the first substratification, it's a two-substratification approach, is patients who actively smoke, patients who have fistulae, patients who have rapidly progressive disease in their early onset, or patients with prior resections, particularly if they've had rapid recurrence. And that's a subset of patients that we see. In contrast, we will see many patients that have long intervals between resections, who have long-standing fibrotic stricturing disease, who do not need to necessarily be placed on a biologic. The second component of substratification is that those patients who do not fall into one of these groups, it's very appropriate to do a colonoscopy at 6 months to 1 year and look at the Recurrent score. Everybody here is familiar with that, with the I, which stands for neoterminal ileum. Only a few little aphthous ulcerations versus severe disease. And in Recurrent score 0 or 1, there's a very low risk of endoscopic progression. And we will see many patients who fall into that category, who will do very well long-term, and who do not need to immediately be placed on a biologic. Whereas substratification can then tell us about the patients who do need appropriate therapy. And so because of this ability, we need to rethink our strategies, particularly in complicated patients, and do surgery first, and then appropriately use biologics and/or immunomodulators subsequently, I think. The third area in which I see a lot of mistakes made is C. diff. This just summarizes some very nice studies from Dave Bignon's group by Isa and co-workers, done at University of Wisconsin a number of years ago, showing the increase due to C. diff leading to hospitalizations and colectomies. We're all aware that the incidence keeps climbing. There have been many articles about this. But what we forget is that this can lead to increased mortality, colectomy, etc. We can see this in patients who've lost their colon, in patients who have high small bowel output, for example. One of the mistakes that's easily made, and this was pointed out by Isa and co-workers, is that the absence of pseudomembranes does not mean the patient doesn't have C. diff. That is, in normal patients, C. diff is associated with pseudomembranes. However, in ulcerative colitis and Crohn's patients, at least half do not develop pseudomembranes. And so obtaining aspirates for C. diff is critical at the time of colonoscopies in our patients. And it's amazing how better the yield is when the specimen is taken immediately to the lab. And of course, the cell culture toxin assay is not done very much. It's the ELISA assay, which has been so problematic for us. Fortunately, with the new PCR assay, the improved sensitivity is helping tremendously in recognizing cases that we were missing before. A big mistake is that many patients are started on Flagyl. In IB, that's appropriate in the normal population, but in patients with IBD, it's critical to use vancomycin. Many of our patients are non-responsive to Flagyl. Fidaxomicin is actually not yet completed the studies in terms of IBD. The studies are completed for the normal population, but not our C. diff and IBD patients. And so the reason it's so important is that there's an extremely high recurrence rate, and that's what we see. That we'll see patients who over the course of 2 or 3 years will develop C. diff multiple times. And some of those go to colectomy because it leads to severe long-standing disease and makes things worse. So we have a variety of strategies, the vancomycin every other day taper, perhaps following up by rifaximin, perhaps Fluorostor. Of course, there are studies on fecal transplant that are underway. Most of the fecal transplant literature is in the normal population with refractory recurrent C. diff. The last issue to remind people of is the risk of infections, which include older age, malnutrition, additional illnesses, severe disease, exposure to pathogens, use of prednisone and narcotics. We're all familiar with this, but the issue is, again, the need to prevent infections in our patients. This study by Torrunner and co-workers showed very nicely that as you add more drugs, you get a higher risk of infections, with the critical thing being at the bottom, and that is if a patient's on immunomodulators plus biologics plus steroids. And we all say, oh, never happens. But it does, because we'll have patients who are on 6-MPA azathioprine who fail, who we put on steroids, and then we put them on a biologic, and we forget that 6-MPA azathioprine, for example, have a 2-month half-life. So even if we stop it, and a lot of times we continue it, we very often will have patients on 3 different immunosuppressive classes, and the risk of infections in that group is particularly high. This very nice study from Gil Melmed showed that many of our IBD patients, very few are getting appropriate vaccinations, only 9% getting pneumovax. And very often, a nice study done by another group showed that the gastroenterologist often says, well, it's the primary care physician's responsibility. The primary care physician said, you, the gastroenterologist, are putting the patients on these drugs, it's your responsibility. And the patient often gets lost in the middle. So just to remind people that DPT, HPV, influenza, as everyone knows, pneumococcus pneumonia needs to be given every 5 years in our patients, not every 10 years. Of course, Hep A, Hep B testing, meningococcal when appropriate. Varicella, MMR, is live, so it can only be used when our patients are not suppressed. Now, Bactrim is not a vaccine, and I am aware of that, but we need to be aware that we are often putting our patients at risk for pneumocystis. And having done it once and having the pulmonary people tell me, gee, in our cystic fibrosis patient, any patient on prednisone 20 milligrams a day or higher goes on Bactrim DS every other day. Am I feeling like an idiot when they told me that? We're not using PCP prophylaxis as much as we should. These are the live vaccines. I think we've all aware of them. particularly note, obviously, the shingles, the nasal flu, mist, oral polio. We've all learned about yellow fever from our students who travel to South America or Africa, that's a live vaccine also. And the critical issue, as shown at the bottom, is that the inactive vaccines can be given at any time. If a patient's on 2 immunosuppressives, there will be less of an immune response, but on 1 immunosuppressive, the vaccines are usually effective. And as shown in the top, vaccine use in IBD really should, in terms of live vaccines, should be avoided 3 weeks prior, and not until patients have been 3 months off steroids, etc., immunomodulators and anti-TNFs. So just a few comments on a few areas which I think are important. So thank you very much, and we will go on to the next talk.
So let's talk about the ulcerative colitis. These are the surgical options that are available right now. Subtotal colectomy, total abdominal colectomy with IRA, total proctocolectomy with endoileostomy, content ileostomy, a cock pouch, and the gold standard, for, in my opinion, for the surgical management of ulcerative colitis, which is a J-pouch procedure. The subtotal colectomy ileostomy is a procedure of choice when the patients are acutely sick, or they're on high-dose immunomodulators or steroids, or they're obese, they have associated comorbidity. This is the procedure that we'd like to do and stage the procedure. We happen to do more and more this procedure because of the fact that we believe the patients start to come to us a little bit sicker than what we'd like to see, at least comparing to past. And in this procedure, we'd like to leave the rectosigmoid stump tagged under the fascia, so if the rectum blows out, at least it becomes a wound infection rather than a major pelvic abscess that may impact the patient's fertility and can create a major surgical problem to deal with. So total colectomy ileorectal anastomosis is still a good choice in certain situations. These situations are specifically patients where the diagnosis is not clear. There's a significant concern with the Crohn's disease where the rectum is normal. But in the last decade or so, when the patients are very worried about the concern of infertility, this can be an option as an alternative, because the one that impacts the fertility in female population is when we get into the pelvis. So it's an alternative in patients either for concern for fertility, concern for the diagnosis of intermittent colitis, like you have a concern for Crohn's disease, or patients with a stage 4 cancer with the associated ulcerative colitis. These are the indications that I emphasize. Total proctocolectomy and ileostomy is still a good option if the patient is not keen on a restorative the procedure, especially patients with significant comorbidity, obesity, poor sphincter function, the rectal cancer, itself that we cannot put the patient back together, and a patient with a failed ileal pouch anal anastomosis. On this side of the Atlantic, this is a procedure that has been a little bit abandoned, in most of the centers except few sites. Our site is one of them, and also north of the border, Professor Crohn led the significant amount of effort in this thing, but this is still a very good procedure in patients who are not candidate for a J-pouch procedure. In this technique, patients do not need to have a permanent ileostomy where there is a pouching system. There's a one-way valve mechanism in there that helps the patient to be able to put a tube 2 or 3 times a day, so they will be able to empty their pouch, so they avoid wearing a bag. Indications are patients who are not a candidate for a J-pouch procedure itself. The problem with this procedure, it needs a motivated patient and it's a motivated surgeon. Significant amount of revision rates, but the survival is pretty good. What happens is, if the patient gets this procedure, they love it. They never want to go back to a permanent ileostomy. So this is a procedure, even in our centers, only 2 or 3 of us does it, led by Dr. Kiran and Dr. Deed. So it's very important subspecialization on this technique itself. So, that we channelize these patients who are a candidate for this to 2 to 3 guys. The ulcerative colitis, in our opinion, is managed best with a J-pouch procedure. In this procedure, we take the colon out, create a J-pouch, put the things up to the anus. How do we do this procedure? We treat this like a cancer posteriorly. Lateral and anteriorly, we stay a little bit close like a benign disease as long as the patient do not have a cancer itself. We come across to the point where we put a finger to the anus at the proximal interphalangeal area. That's the area we come across with a staple line. We prefer to do a J-pouch procedure with a double stapling technique. This is a device that's a circular cutter and stapler, and do the anastomosis itself and make sure we have 2 intact donuts. Check for a leak. If there is no leak, we would like to give 85 to 95% of the time an ileostomy for 3 months for the closure, so the hookup can heal up. If the patient is not a candidate for a J-pouch, there's a reach issues. The S-pouch can reach another inch or 2. We would like to do a S-pouch as an alternative. These are the controversial topics that I would like to talk to you about the place of J-pouch procedure. Is it okay to do it on the elderly population? The answer is yes. It needs to be a well-fit person. The quality of lives are very comparable to young patients. The function is a little bit worse. So the punishment fits the crime. If the one is a well-fit patient, this is still a very good procedure. Age is not a good cutoff not to give one an option. How about the toxic colitis? I think the toxic colitis patient should be staged, not to have a J-pouch procedure from the get-go. The morbidity is very high. Patients with a cancer, rectal cancer, as long as we can obtain a clearance from the oncological standpoint of view, I think this is a great procedure to do. The thing that we need to know, if the patient requires radiation therapy, this radiation therapy needs to give him preoperatively. If we give it a post-op radiation therapy, rest assured that patient is going to lose their pouch. So for that reason, we do not give post-operative radiation therapy as long as the patient is planning to lose the pouch. Mucosectomy and stapled anastomosis. There are 2 points about this thing. Groups like us who believes the fact that the function is better, anastomotic complications is better in stapled anastomosis. The other opponents, they say the fact that the symptomatic anal canal inflammation, colitis, and the risk of dysplasia are concerns. So how true is that? This is our patient series that we published several years ago, over 4,000 patients. Our results show the fact that, at least in our hands, the function was better, and the complications were less in patients with a stapled anastomosis. When it comes to the symptomatic canal inflammation, the chance of that happening is low. If it needs, you can use a 5-ASA products like a Canasa. That may be a help out for these patients' symptomatic colitis problems. The risk of cancer, it is a concern. We have total of 11 cancers that develop over 4,000 patients. The critical thing that what can be seen in these patients, these are very insidious cancers. What is the common denominator in this slide? It happens on the setting of a chronic inflammation, either chronic colitis, chronic enteritis such as pouchitis, or a Crohn's disease. So if you have patients who are risk group of these patients, I think they need to be in strong under surveillance. Do we still do some mucosectomy today at the Cleveland Clinic? Yes. If the patient has a low rectal cancer or a dysplasia in the colon and rectum in the lower 2/3, we prefer to do a mucosectomy in this setting rather than a stapled anastomosis itself. Now, the type of the pouch. Does the type of the pouch matters? It doesn't. J-pouch is the preferred technique. It's easier to make, so that's the reason we look like the J-pouch procedure in this setting. Avoidance of ileostomy, whether we should be giving ileostomy someone at the time of the J-pouch creation. It depends. This should not be used for marketing purposes, like we're not going to give you an ileostomy, because most of the patients do need an ileostomy. The message I tell to my fellows is that you need to have some experience in your shoulder before you consider it. So you need to have an experienced surgeon, elective procedure, motivated patient, low dose prednisone, no immunomodulated agents, and the procedure needs to go uneventfully to consider not to give somebody an ileostomy. How about the indeterminate colitis? It's okay to do this in this setting as long as we understand the fact that these patients may have an increased risk of Crohn's disease. However, the quality of life function and the failure rates are similar with the ulcerative colitis patients. That's something that the patients need to know. Coming to the Crohn's disease, this is our series. We had 204 patients with a median follow-up 7.4 years that had a Crohn's disease. Now, out of these, only 20 out of 4,000 patients had a known pre-op diagnosis of Crohn's disease. So I don't want to give an impression of we do a Crohn's disease on somebody who comes to the Cleveland Clinic. Most of the diagnoses were done at the specimen, so there's nothing we can do about it. At that time, the patients actually did well. The patients who did worse are the ones that where clinically the patient presented itself as a delayed diagnosis, or the patients had a pouch vaginal fistula, or who had a postoperative sepsis itself. Infertility, it's a concern, it's a reality. The patients need to know about this thing beforehand. There's a threefold increase after this J-pouch procedure. The type of delivery when it comes on these patients after J-pouch procedure, it's a big controversy. The literature says on a meta-analysis, vaginal delivery is safe. However, in our experience at the Cleveland Clinic recently, we did a publication with Dr. Kiran that in our hands, at least, the C-section gives a better results, after a J-pouch procedure, and recommend our patients a preemptive C-section. Inflammatory and IPA, this is at least our opinion, most of the surgeons in our department. This is nothing against the drug. There may be something related to the fact that maybe patients are coming to us later. But at least in our hands, when we have an Inflamex use in ulcerative colitis, there is an increased risk of early and late postoperative complications and greater need for an unplanned or staged procedure itself. And this is something I think we need to be presenting to the patients, at least in our opinion, before we start them to Inflamex the possibilities related to surgery. I think the laparoscopy and ileopouch anal anastomosis is an excellent option. We revolutionized the concept of a single port procedure where we can do this whole procedure from a single port itself. Truthfully, the benefit of this thing proven so far is cosmesis. But in my opinion, on a young ladies that were or the guys that who the cosmesis is very important is an excellent option to be able to consider. This is the results of our patients, over 4,000 patients, 97% of the patients that they will undergo surgery again, and close to 98% of patients they will be willing to recommend the surgery other in their situation. Briefly about the Crohn's disease. When we talk about the Crohn's disease, it's unfortunate to see the fact that still we need to be, as surgeons, will have some interaction with the Crohn's disease patients at one point in their life. The operating options are bypass, resection, and strictureplasty. The bypass options currently are generally avoided. This was the first procedure that was done, and actually one of our presidents, President Eisenhower, got one of these procedures for Crohn's disease. It's an iliotransverse bypass, currently has not been done because of a concern of a cancer in the mucosal. It's occasionally acceptable in cases of the gastrointestinal disease and a complicated ileocecal phlegmon where there's a major infection that we cannot do the resection itself. Resection itself is the number one choice. A conservative margin of resection is quite all right. We do not have to have a pathologically proven margin to get a complete clearance because it doesn't provide any benefit. Contrary to that, we lose a lot of unnecessary small bowel. This was a study that was done by my mentor that actually gave this clear concept. All you need to do is feel. You feel the fact that on the area close to me, you need to have your thumb to be able to touch the index finger where the mesenteric thickening doesn't exist. That's the area that you need to be doing the anastomosis. Anastomosis itself doesn't matter the type of anastomosis to impact the recurrence. Surgeons thought about this possibility. The bigger the anastomosis we made, it may be better. The last study that was done by the McLeod North American Study Group showed the fact that it doesn't make a lot of a difference what type of anastomosis we do. It's the pre-anastomotic area where the Crohn's come. So it's the surgeon's procedure of choice. Patients, when do we give a stoma? If the patient is sick, septic, there's an undrained sepsis, good amount of blood loss, complicated procedure, and malnourished, these are the ones that we are liberal about giving a stoma, especially in this DNH, in the setting of the immunomodulators, that we like to preemptively divert a good amount of patients in this setting. Strictureplasty is an excellent option in multiple strictures or a long segment or a patient with an impending short bowel syndrome, but it needs to be a non-phlegmonous fibrotic stricture. If there's a fistula, if there's an abscess, we cannot do a strictureplasty in this setting. Different type of strictureplasties exist. This is the most common one for short strictures, where we make a longitudinal incision and close it transversely, so it makes the obstruction to be relieved. The other type of procedure is a Finney type of a procedure. It's a side-to-side anastomosis itself for strictures 10 to 20 centimeters itself. Lastly, it's a Michelazzi structure that greater than 20 centimeters of the strictures with the impending short bowel syndrome. I think it's an excellent option to consider, and the patients get a good results with this. Coming back to the specific disease size itself that we're going to talk about. And these are specifically the gastroduodenal disease. The controversy here, bypass versus strictureplasty. Strictureplasty gives an excellent result as long as feasible. Gastrojejunostomy, in our opinion, is one of the worst procedures that the surgeons have done. It impacts the outcome. The stomach cannot function, so we'd like to avoid this as much as possible in this setting. How about the colonic disease, the total colectomy and the anastomosis? Some people advocated to avoid any early recurrence, or a segmental colectomy itself. You know, when you look at the results, it shows the fact that the recurrences are pretty much the same. And lastly, our recent results by Kieran et al. Published in 2011 show the fact that when we have a segmental resection, we may be able to keep the gastrointestinal patency a little bit longer. So if as long as it's feasible, segmental colectomy is our preferred technique right now. The proctectomy techniques, I think what matters is here, however you do, you gotta be careful that you do not leave any mucosa behind. For that reason, endoanal mucosa proctectomy is our preferred technique. The Mount Sinai group emphasized this point from New York. If you do a stapled proctectomy, you may not realize the fact that you left a little bit cuff behind that may become cancerous down the line. It can give a disastrous outcome. And perineal disease, this is something I love to have the immunomodulators on board. It is more common on the colonic disease itself, and the fact that there's a controversy whether the presence of a proximal disease impacts the surgical outcome. We believe that as a group, so if there's a surgical disease in the abdomen, we would like to resect it to improve the outcome of the perianal disease. These are different type of techniques available for this problem. Non-cutting sedum is an excellent therapy. I think some of the things that differs as a surgeon and a gastroenterologist, our priority regarding the patient with Crohn's disease, keep the anus, not to heal the fistula, as long as it's not a rectovaginal fistula. So less is more in this setting. Put the sedum there, keep it a year, pull it out if you have to at the end of the year, so it controls the sepsis. It's still an excellent option. Fistulatum is a good option. We gotta be careful not to overdo it, risk of incontinence and unhealed perineal wound. A rectal mucosal advancement flap specifically for the rectovaginal fistulas is an okay option. This is a technique I think we need to be improving, making it better. We're still not perfect on this thing. The results are not that great. And the rectal sleeve advancement flap is also a good option if there's a good amount of disease in that area with some success. But recently we adapted the old procedure, which is a pull-through procedure in patients on selected cases where they're very reluctant to accept a permanent stoma with a normal colon, sick rectum, and anal canal. We do a proctectomy, bring the things out, so we allow the things with a secondary healing so this will not fall apart. And we do have some 60% to 70% success rates over 2 to 5 years times. It is a selected case, the radical procedure is a good option to consider. Fibrin sealing and the plug, we have pretty dismal results in our series, open-minded about the new innovations, but that's something that we need to share that with you. Our results as not great. Lastly, fecal diversion. It's a bridge to a permanent ileostomy, unfortunately. Cooling it off do not help on these patients, at least even in the setting of the immunomodulators. I think patients need to know that. I'm grateful for your time, and we're going to get started with the case studies. Thank you very much.